Hi, it's a beautiful day. Thanks for coming. So I'm Jennifer Talley. I am the Assistant Director of the Mental Health and Substance Abuse Counseling Concentration here at the New School. I'm also the Assistant Director of the Center for Optimal Living. And then along with Dr. Tatarsky, we have recently launched a harm reduction psychotherapy certificate program here at the New School, and we're in our second year. So our thinking behind this event is that this is the first of a series of events really designed to bring communities, family members, clinicians, people that are interested in making change and really looking at the system that we have right now that exists for treatment, the policies that are in place, and really working together to make meaningful change that's going to help people. So with that in mind, I'm going to introduce Dr. Scott Kellogg, who is going to be our moderator for this evening. And then we're going to have each panelist come up and speak for about 10 minutes or so, and then we're going to open it up for questions and discussion with you as a group. There are snacks and drinks back there. Bathrooms are over there as well, so please feel free to enjoy some snacks and enjoy this event. Thank you.
So good evening. That sounds very anemic. Let's try that again. So good evening. Good evening. All right, that's much better. So one of my hats I wear is that I'm president of the Division on Addictions of the New York State Psychological Association, and we're one of the co-sponsors of tonight's event, and we're very pleased to have the chance to support this event, and I'm very pleased to have the privilege to moderate. I teach a class in a psychology of addiction at one of the rival schools, NYU. And one point I make to my students, and I think it's a very important point, is that when we look at drug policy, not only in the United States, but drug policy throughout the entire planet, there is an ongoing debate about people who are addicted or people who have serious issues with substance use, which is, are these bad people who need to be punished, or are these sick people who need to be healed? And seeing Ken Anderson here, I would say, and so there's a minority voice saying, actually, it's neither of these. It's simply a personal choice. But that's not a dominant view yet. And I think we often can look at the question of drug policy about, should we punish these people? Should we heal them? I sort of joke, but it's only half a joke. People like therapeutic communities because we're half punishing and half healing. We kind of split the ambivalence about whether these are bad people or not. But I think what we're going to see tonight is really a shifting towards the healing perspective. That these, the parents, these are my children, I love these kids. I'm looking forward to see Major Franklin from LEAP speak about law enforcement, but just all this issue about what are we going to do with these people and how are we going to care for these people. These are our children, these are our family members, and things like that. In Alcoholics Anonymous, they say keep it simple. And that's good if that works, but as Dr. Tatarsky has written, complex problems require complex solutions. And I think we actually did a conference on this ourselves, but this idea that addictions are very complicated. Problematic substance use is very complicated. Even recreational substance use is very complicated. The complexity lies within the person themselves, within the family, in the relationship with the treatment providers, with the legal system, with society at large, and with the forces of social oppression, which will open the door to harm reduction, of course. So those are some of my thoughts, and I'm very pleased to begin now. The first presenter today is going to be Katz Beyer, who, as you'll see in a minute, is like a hurricane of family energy and love. She comes both from a professional background and a personal background. She's one of the co-founders of Families for Sensible Drug Policy. If you're not on their Facebook page, you're missing all the action. So I suggest you go on their Facebook page immediately. On your phones, you can join right now. So Carol, we look forward to hearing your talk.
Well, hello, everybody, and welcome. It really is a privilege to look into the audience and to see so many new faces, new friends, and old friends, and soon to be good friends in the audience. My day job is helping practitioners with sensible practice management strategies. And when my own children became impacted by opioid addiction, I realized fairly quickly that there was nothing sensible about the way they were being funneled out of school, out of soccer programs, off the baseball fields, and into intensive outpatient programs where they were forced to call themselves addicts, where the family was divided because mothers were called enablers and codependents, and subsequently every past, present, and future digression was the mother's fault. So we slept with one eye open, we locked our jewelry in the trunks of the car, and we were advised that with every problem, with every misfire, with every positive drug test, we weren't being tough enough. So we were told to use law enforcement, that that was the right thing to do. And something about that didn't appeal to me. And when I was told that my children need to work their own program, and I needed to work a program, and I walked in to Naranon, I heard one war story after another. One child had passed away. Another child was in prison for the 10th time. Yet another child was raped and lost a child because her mother wouldn't let her in 30-degree weather into the home. And I said, this is really wrong. And I got on LinkedIn, and I have to give a shout out to Ziggy Santini, if many of you may know him from LinkedIn. He's over there. He's here from Spain, and he actually had what is probably the longest thread in LinkedIn history, and it was all about what professionals should do as far as referring their clients to programs. And I said that in order for clients to be referred or patients to be referred anywhere, they need to be screened appropriately. They need to establish benchmark goals. It simply isn't enough to say, go off with a bunch of strangers who are in various stages of relapse and further along in their addiction, not know where they're going, and just say everyone needs to go there. And as they would test positive, they would be referred to different programs. Some of them wound up getting arrested, getting on probation, and then I realized that something else was really wrong, because if relapse is an expected part of this complex disorder, then why do we sanction criminally when a child relapses or a young person relapses and they go to probation and they're told that they have to be sanctioned in jail? And so many children don't show up for probation appointments. Many young women who may be pregnant don't get the help that they need in counseling, and so on and so on and so on. And I realized that help was needed, and was I the only person that thought this way? And by the looks of things here, apparently I'm not. So I really want to thank Dr. Andrew Tatarsky, because about 6 months ago, my co-founder Barry Lessin and I came to Jen Talley and Dr. Tatarsky, and we expressed our feeling that we needed really for communities to work together, for there to be a seamless integration of healthcare and law enforcement and clergy. And to that extent, I don't think it's an accident that the Pope is here. And the Pope is stating that a society should be measured by the way that it treats its marginalized population. And I say the time is now. We have an epidemic that is the all-time high in history. We have co-occurring disorders and subsequent secondary conditions, and from $300,000, I'm sorry, the dollars come for the profiteering in the millions from privatized prisons that are making money off of our children who are commodities. And now from 2006, 300,000 people, we now have 2.5 million people in our prison systems, and these privatized prisons are making billions and billions of dollars. And Colombia, I believe, just stood up and said, you know what, we are not going to welcome any of these corporate organizations that are buying into this, that are subsidizing us, that are funding it. And I call upon everybody here to endorse in the same way, to realize, to stand up and say that no longer will we allow our children who may be experimenting only in the schools to be drug tested and funneled out of their peers and funneled away from their communities forced to say that they're an addict when they're maybe 16 or 17 years old. So I'm very, very happy that everyone is here, and we have such an exemplary panel that I don't want to take up another minute of time because I'm very, very excited to hear the rest of the panel and what they have to say. And I just want to let everybody know the cavalry has arrived, and thank you so much.
Next, we're going to hear from Barry Lessin. Barry Lessin is a psychologist, psychotherapist from Pennsylvania. I've had the privilege of meeting him, being able to talk to him over the last few years. And as I think he'll tell you in his talk, he's gone from a journey from being a kind of a traditionalist, perhaps therapist for addiction, to having a sort of a whole awakening and a whole new way of looking at things and embracing harm reduction and complex views of addiction. So, Barry.
I am a harm reduction psychologist, and this means that I embrace a philosophy in my work that acknowledges the rights and uniqueness, the rights and uniqueness of each person, and I strive to empower the people that I work with by collaborating with them to help them make behavioral and lifestyle changes. I view people struggling with substance use as human beings first, and appreciate that we are brothers and sisters, parents and grandparents, students, members of the community, employees, who also happen to use substances. My harm reduction approach is based on the knowledge that human beings will always engage in behaviors that carry risks and respects a person's right to make choices. This shifts the focus from attempting to restrict or prohibit the risky behavior to reducing the negative consequences associated with them. I know that most of you and your family members have not experienced this type of treatment approach. I know that you've suffered lots of damage and poured your hard-earned resources and energy and hearts into a treatment industry that has not only failed you, but traumatizes by imposing on you a patriarchal, confrontational, one-size-fits-all treatment model that hasn't changed much in 50 years. I know this because I began my career as a traditional addiction treatment provider, trained in this mid-20th century approach, which is still used by a majority of treatment providers today. In the past decade, though, my career took a dramatic turn, profoundly affected by a couple of factors. One was personal. When my family turned to me for guidance in dealing with my nephew's substance misuse and mental health problems, I became aware of the profound flaws in my treatment approach as I watched my so-called expertise actually contribute to making things worse for my nephew and my family. Another influencing factor was professional, when young people in my practice started dying from accidental overdose. The confluence of these issues compelled me to start looking for answers to the larger picture of the public health environment that determines the landscape for those of us working in addiction treatment, for those of us that work in the field. What I saw from the wider perspective made it easy to get these answers, and these answers disgusted me. I became aware of the shameful public health policies in our country disguised as a war on drugs that criminalize and stigmatize people who use drugs. I learned that the war on drugs is really a war on our children and our families. After spending many trillions of dollars in over 40 years to address the problem, the amount of substance use in our country has not changed much at all. What has changed instead is a systematic, exponential increase in the incarceration of millions of people for nothing more than drug law violations. I learned about the school-to-prison pipeline that Carol referred to, and it's a racially based punishment approach that sets up our communities to be funnels to failure. When I lifted my head out of the sand, these oppressive drug policies shined a glaring light on how the treatment model that I was trained in and participating in was failing my clients and essentially abandoning our families. It motivated me to learn more about substance use and its treatment as a public health issue. And when I viewed it through this lens, it was then that I learned about the value of harm reduction. Harm reduction undergirds many public health policies because it places self-empowerment of people at its center. The empowerment of substance users is lacking in traditional treatment, And it's not only lacking, but it reinforces the stigma by blaming the patient when the treatment fails, and it blames our families by giving us shameful labels like enablers and codependent. I began my public health journey in overdose prevention, working with families who have lost loved ones due to overdose and whose pain and rage at the failed treatment industry affected me at many levels. Learning about their painful journeys, their grief processes, their resilience in their lives and in their sorrow, it inspired me to challenge my own internalized judgments and stereotypes about substance use and users. And I recognized that the acute stigma that they were feeling was reinforced by my treatment approach. The awareness of my personal and professional identities as a family member and clinician, plus the consistent feedback from the families about feeling traumatized by treatment, encouraged me to shift my public health focus to create a safe space to educate our families and empower them by creating opportunities for them to become advocates. Carol was following a parallel path when we formed Families for Sensible Drug Policy to bring together an international coalition of stakeholders to advocate for the creation of a new vision and approach to help those with substance use and mental health problems, and to enable better access to effective treatment and to reduce the harmful consequences of oppressive drug policies, with the goal of empowering families, restoring health, and saving lives. Existing policies contribute to a damaged treatment system that is broken because of the treatment industry. My fellow treatment providers allow ourselves to be part of this broken system by using outmoded, ineffective treatment methods that contribute to the deaths of countless thousands of people. It's broken because of the lack of regulation and oversight allows substance users to be treated as commodities that are more important in filling beds than offering effective outcomes. It's broken because we allow treatment to be intricately linked with law enforcement, throwing people who use drugs into a system that incarcerates them for continuing to use drugs. As a result, billions are spent each year on incarcerating users that otherwise could be spent on treatment for those who want it or need it. It's broken because rather than using science to guide its treatment decisions, it aligns itself with a moralistic, prohibition-based agenda that doesn't distinguish between substance use and misuse, and coerces people into treatment who don't want it or need it. I'm ashamed of being part of our broken treatment industry that promises rehabilitation, but avoids using established research on how to treat what essentially is a mental health condition. When people relapse with other complex problems similar to addiction that require lifestyle changes like cancer, heart disease, and diabetes, we don't blame the person for their treatment failures. We don't tell them that they're in denial, or that they need to be ready, or that they have to hit a bottom. When people relapse in treatment for other conditions, we don't throw them in jail, we don't kick them out of schools, we don't refuse them educational dollars, we don't refuse them aid for their education, and we don't throw them out of our homes without support. With other illnesses, with other conditions, we respond with scientific, common sense, and compassionate approaches, and we look at the treatment methods that are failing them, and we do more research to provide better treatment. It's time that substance use disorder treatment, like other conditions that affect our public health, be informed by similar approaches. Policies like these will reduce the stigma and shame of substance use and more likely lead us to better treatment better treatment outcomes. But I'm here tonight not to only bring attention to these failures and the need for change, but also to share my excitement about being part of a movement that's growing with national conversations about enlightened drug policies and progressive addiction treatments. Forums like this offer an opportunity for us to share our vision and our vision of the future of substance use disorder treatment. The future of treatment will be integrated into a comprehensive public health continuum, from drug policies that support, not punish, to early medical interventions including primary care physicians and emergency room staff, to reality-based education programs in the schools and communities for educators and parents. The future of substance use disorder treatment will have all medical providers adequately trained in addiction medicine and treatment providers trained in self-empowering, individualized treatment approaches that embrace people's uniqueness and collaborate with them to develop treatment plans relevant to their needs. The future of treatment will acknowledge the importance of family health. Family therapy will be a part of treatment where appropriate and fully integrated into a person's treatment plan, to offer a healing process and to empower parents and loved ones by offering a roadmap to help them be more effective as family members. The future of treatment will acknowledge that teens and young adults' substance use is not assumed to be part of a disease process, but occurs in the context of a young person's process of development, and will focus on helping them to develop strategies and skills to make healthier choices and manage their emotions more effectively. It will offer academic, peer, and community supports to match the young person's need. Our vision that treatment will be more effective when it's in the context of a public health, our vision is that treatment will be more effective when it's in the context of a public health continuum and when it's science-based, empowering, and collaborative. Our families deserve nothing less than the best that we have to offer. Our vision includes drug policies that support, not punish, and in turn both inform effective treatment and make it more accessible. Tonight is a beautiful example of the support, the passion, and the solidarity of our collective communities coming together to promote sensible drug policies. And we won't stop until our vision becomes a reality. Thanks.
As I think Carol pointed out, the war on drugs has really been a war on people, and the horrors of the school-to-prison pipeline, which we'll hear about in a minute, are certainly dreadful, and so many lives wasted, and opportunities and visions and dreams destroyed. Given and all around the world, the oppressiveness of punishment as a way to treat addiction, although I think at the moment we're beginning to see a few, maybe honest, bright lights or a few things in motion that are quite interesting. Certainly Portugal, which I think has decriminalized all substances, has been, an amazing experiment that many of us are looking to see how that's playing out, and quite delighted with the results. And in the LEAD program, which I think is taking place in Seattle, if I'm not mistaken, another program just taking people right to treatment, skipping the whole prison thing if they're having trouble with addiction. So with that as a background, I'm pleased that Major Neill Franklin from Law Enforcement Against Prohibition will now be speaking and giving us his wisdom.
So thanks for having me. It's a pleasure to be here. Wonderful train ride up to this wonderful city this morning, so just pleased to be here. I hope it doesn't seem or sound like I'm reading, but I had to write these notes down because if I didn't, we'd be here for a very long time with me talking about this. My brother's my pastor, and I have a lot of his traits, and once we get talking, we can talk for quite a long time. So, again, I hope it doesn't sound like I'm reading, but I want to just cover some things real quick. Beginning with the title of, part of the title of this event tonight, which is bringing communities together. And just listening to a couple of the prior presentations, this is really some good stuff. I mean, typically it's been, as you look back a little bit, those who have been advocating for policy change as it relates to illicit drugs have been, organizations like Normal, who people just want to be able to freely use, for instance, cannabis. It's been great advocate organizations that really come from a different perspective than one of those who have been affected by the abuse of drugs. And we're starting to see the shift, a much needed shift in this fight to transform our drug policies in this country. And I'm going to talk a little bit about this from a policing perspective. And I'm with Law Enforcement Against Prohibition, and can I get a show of hands of those folks who really know who we are, LEAP, Law Enforcement Against Prohibition? Okay, just briefly, for those who don't, we are an international nonprofit organization of criminal justice professionals. That's police officers, judges, criminal prosecutors, corrections officials, parole and probation, federal agents who have been on the front lines of the war on drugs. Personally, I've been on the front line of the war on drugs for 34 years, up until 2010 when I became the director of Law Enforcement Against Prohibition. And we have seen this abject failure that is actually counterproductive to the one thing that we signed on for, which was improved public safety, to better public safety, to have safer communities. And it has been a complete disaster. It is the foundation for most of the violent crime that we have in our communities today. And that's just in the United States with the gangs and organized crime and the fighting for drug corners and selling these drugs. And I'm not even going to get into south of our border in Central America, where the violence is just completely unbelievable and out of control. So let me move through this presentation rather quickly because we have some other speakers. So why is there even such a need, for this conversation of bringing communities together? And I'm talking from a policing perspective. There exists, as I think many of us know, an obvious disconnect between police and community. And I hate to use the term police and community when in fact the police are the community, where they should be. And this is what I mean by this. Robert Peel, who many of us consider the father of modern-day policing, is responsible for what is referred to as the Peelian principles, 9 basic policing principles constructed in 1829 in England by 2 of his commissioners. And these principles were to guide police departments and their police officers in how to conduct business, how to go about policing, and the profession. Principle 7, number 7 states this: police at all times should maintain a relationship with the public that gives reality to the historic tradition that the police are the public and the public are the police. The police being only members of the public who are paid to give full-time attention to duties which are incumbent upon every citizen. Lost my place, sorry about that. Incumbent upon every citizen in the interest of community welfare and existence. So we are one and the same. But we've gotten to this place, this culture, this environment of the us versus them mentality, and you really see it today with the recent occurrences that we're seeing around this country with police shootings and deaths at the hands of our law enforcers. Policing actually used to be about harm reduction, and that's kind of like what we're talking about here tonight, harm reduction, saving lives. But unfortunately today, we have abandoned our harm reduction efforts in a sense. We have become warriors. We have become soldiers. Think about the policing uniform. I guess you can see the gray hair in my beard. I've got some years on me. And I think about the police officer's uniform, and even when I started policing 3 decades ago, nice white shirt, crisp slacks, shiny shoes, a very attractive, friendly appearance. But think about many of the policing uniforms today. The military-style pants with the blouse inside the boots. When I wore a ballistic vest, it was inside the shirt. Now it's outside. It looks like the flak vest that military folks wear when they're in war. Many times you even see police not even riding motorcycles, but they have helmets on. Normal patrol. and some of the gear that they have. Militarization of our police forces. We have become soldiers in occupied territory. But let me move on. And, you know, this is really about the war on drugs. The vast majority of this change is about the war on drugs. The policies of prohibition cause us to focus on the drugs. And by attacking the drugs, the people end up as casualties of war. Arrest, prisons, unresolved addictions, HIV, job loss, death. Health-centered policies place priority on the people. You mentioned Portugal. In Portugal, where they've done this, they've made a shift from policing to health. What has happened over the past 13 years in Portugal? A 71% in new cases of HIV infections for intravenous drug users. A 52% in overdose deaths from illicit drugs. We're going up in this country considerably. What about the young people? Middle and high school kids, a 22 to 25% reduction in overall drug use. Why? Because twice a year they send a healthcare practitioner into the schools to teach the truth about drugs and their effects. It's what we need to do. At one time, U.S. law enforcement was engaged in the harm reduction philosophy. And I want to mention someone here, another person who's important in the policing history. This gentleman's name is August Wollman, here in the United States. He used to be the chief of Berkeley Police Department. He was at one time also the head of the International Association of Chiefs of Police. This is what he said back in the 1920s when we were also moving into alcohol prohibition. And we all know what a success that was for the 13 years that it existed. August Wollman says this. This is a police leader in the 1920s. Stringent laws, vigorous prosecution, and the imprisonment of addicts and peddlers has proved not only useless and enormously expensive as a means of correcting this evil, but they are also unjustifiably and unbelievably cruel in their application to the unfortunate drug victims. Repression has driven this vice underground and produced the narcotic smugglers and supply agents who have grown wealthy out of this evil practice and who by devious methods have stimulated the traffic in drugs. Finally, and not the least of the evils associated with repression, the helpless addict has been forced to resort to crime in order to get money for the drug which is absolutely indispensable for his comfortable existence. Should have listened to our forefather in policing. Law enforcement folks should have. So why have the police, in a sense, been dissected from the community? Why the us versus them culture? And then again, it is the war on drugs where local law enforcement was bribed by the feds in 1972 after Richard Nixon started the war on drugs against public enemy number one, the abuse of dangerous drugs. And that federal money, those grant dollars, caused us in local law enforcement to aggressively enforce the federal laws, locking people up. Before you know it, it was about hook 'em and book 'em. Hook 'em and book 'em. Get the numbers in so we could get the grant dollars, fill out the applications, and do it over and over again year after year. Then in the 1980s, Ronald Reagan gave us more incentive, financial incentive, with civil asset forfeiture policies. And before you knew it, we were just locking up any and everybody that had anything to do with drugs, whether you were selling it, whether you were a kingpin, but most of those people who went to prison were users. And today, most of those people who we're locking up are users, people who are addicted and who need health care, not prisons. It's not a whole lot of good happening in prisons. So we continued to arrest as many people as we could. 1970, we had about 400,000 people in prison. Today, it's 2.3 million, or who really knows what the number is? We know it's well over 2 million. And most of those people that we're putting in prison have something to do with the illicit drug trade along those lines. And we continue down this road. And as I begin to bring this to an end, we've become very comfortable with enforcing these policies heavily and consistently in black, brown, and poor communities. If you haven't read The New Jim Crow by Michelle Alexander, please do so. And I'll leave that there. For me, it's clear that what we're talking about here is also the pathway, what we call school-to-prison pipeline. Ahmed Muhammad in Texas, a 14-year-old. Now, this isn't drug-related, but here's a kid in high school with a Muslim name who makes a clock, very intelligent kid, puts it in a case, brings it to school. He wants to show it to a science teacher. Before long, the police are called. He is handcuffed. He is taken out of the school. He is photographed. He is literally arrested for bringing a fake bomb to school. We just don't get it. As we move forward, I want to end with this. Two of the most dangerous drugs known to mankind as relates to social problems and death are tobacco and alcohol. And what have we done over the past few decades in reducing use? Over the past few decades, use has gone down for our young people with both tobacco and alcohol dramatically. How do we do that? We did it through education, we did it through treatment, we did it through social influence. That's how you do it, not through prohibition. That's what we need to do with these other drugs, heroin, cocaine, meth. We need a regulated system. We need one that's focused on health first. We need to take the $50 billion that we currently spend on cops, courtrooms, and prisons, and we need to shift that, like in Portugal, and put health first, put people first, put police at the back of the train. That's what we need. And with that money, we can provide on-demand treatment. We could have supervised injection facilities. We can start treating people who are addicted to drugs like human beings and remove the stigma. That's how you reduce abuse. That's how you get police back together with the community. And that's how we begin to move forward from here. Thanks a lot.
When we look at young people and we look at issues about prevention and the goals of prevention, the goals of interventions around substance use, we know from the research there are basically two things you want to accomplish. The first thing you want to accomplish in high school is to delay the use of any substance for as long as possible. So the earlier the substance is used, whether it's alcohol or something else, the more likely there will be lifetime problems, and the more you can delay that, the better off things will be over the lifespan. And the second goal is between 18 and 21, you want people to use as few drugs or drink as little as possible. That's also a predictor of lifetime problems. Clearly, just saying no is not going to work here. So this brings us to the issue of harm reduction, of moderation, of wise use models, of engaging with people in serious conversations about their substances and how they do that. And so I'd like to introduce Tamara Oyola-Santiago, who's here from the New School, who's from the Student Health Services, who works directly with these issues.
Brought up the wrong one. All right. Hi, everyone. Hi. So I'm going to shift a little and you almost use the new school and the work that I do as a case study, as an example of the kind of programming that could be happening that goes beyond the traditional harm reduction setting. So whether that's individual, with counseling and psychotherapy, or at a syringe exchange program. So we're going to bring it here to the new school and kind of show you what we offer. So I'm Assistant Director of Wellness and Health Promotion, which is the primary prevention branch within Student Health Services. So our population that we serve are the 10,000 degree-seeking students at the university, both graduate and undergraduate. About a third of the student body at the new school is international. And every 2 years, we do this survey. It's called the National College Health Assessment, known as NCHA. And one of the things that comes up year after year, every time we do the survey, is that mental health is a primary issue of concern for students. Substance use is part of that, and that it really does impact academics. So I want to show you some of the data from 2013, and I'll present it because it also justifies why we need harm reduction in a university setting. So in 2013, about 16.5% of the 10,000 degree-seeking students participated. So we have it up about 1,600 respondents, that's on the bottom. And we asked a very specific question about students who used off-label, right, prescriptions. And the two that I want to really call attention, although of course harm reduction could be applied to all of these, but painkillers and sedatives. And this is divided by male, female in the total. But if you look at male, for painkillers, about 8%, right, 7.8, female 7.7, total 7.9. And if you look at sedatives, 7.8, 7.9, about 8.0. And stimulants also, right? Male 12.4, female 8.8 for a total of 9.7. And look at polysubstance use, right? Use one or more of the above. Again, remember, these is off prescription, and these are prescribed. So this doesn't even consider marijuana, cocaine, the illicit ones. These are literally prescription drugs. So what does this data tell me as a harm reductionist working in a university setting? It tells me that harm reduction is needed, that I need to look at polysubstance use, and that I need better data. Because the National College Health Assessment doesn't ask specifically about oxycodone. It doesn't ask the students about opioids specifically, or about cocaine specifically, or about what kind of stimulants. Is it Adderall? Is it Ritalin, etc.? So one of the things that we're looking for in the future is to start to ask and delve a little bit deeper into the data. So one of the things that we did within wellness and health promotion, and I came to the new school in 2009, was that we really wanted to make harm reduction a pillar within the prevention program. One of the great things is that I had administrative buy-in from the start. I was hired as a public health educator who was a harm reductionist. My supervisor knew that, had complete buy-in, and I went into a student health services setting with medical providers, with physician assistants, with counselors, clinical psychologists, who knew I was a harm reductionist, and while they themselves may not have done it the way that I did with the syringe exchange program and kind of like hardcore in the trenches, understood it, respected it, and embraced it as necessary. But how could I, as a harm reductionist, bring the kind of programs that I was familiar with, that have been basically my bread and butter, into a university setting? And that was one of the challenges that I really faced coming at the new school. So we started off really slowly. And I want to give you some examples, and I'll lead you through it so you can kind of see how we went deeper and deeper into hardcore harm reduction. So here we go. So one of the first things that I did was identify who were my colleagues and my allies. I already knew that within student health services, I had them. But where else? As student health services, I operate from the student affairs or student services side, which at the new school, and pretty typical of other colleges and universities, is far away from academia. So I needed to identify who were the professors in different divisions that had harm reduction as part of their expertise. And I needed to figure out, within student affairs, what were other offices where harm reduction could be practiced. The other thing I did was I rewrote, along with my colleague Rachel Nafshay, our public health program plan, our template, our master, our vision. And we really made social justice and harm reduction we see as a social justice concept part of the fundamental tissue, fabric of what we did within public health prevention. So one of the first allies I found at the university was Catherine Perkins from Facilities. And with Catherine, it was really around occupational health. Why? Because her team manages public spaces such as bathrooms across the buildings, and there had been needle stick injuries. So with Catherine, we started to investigate, well, what are the different issues that are impacting facilities and security folks across the university? And we came up with this series of flyers and handouts called Safety Tips. And one of the first ones we did was on bloodborne pathogens. So how did I, as a person who had worked a lot with harm reduction and syringe exchange, do it? So we not just covered what to do if we have an accidental needle stick injury, but let's include prevention and safety across the board. So don't share needles. Use a new needle for each shot. We reached out to MFAR and to IDUHA, the Injection Drug Users Health Alliance, and got information on how to get personal fit packs donated so that we could distribute through student health services and through all of the security desks and through all of the dorms. So that was one way. So that was a very critical ally from the get-go who bought into the harm reduction model because we made it an occupational safety issue. And then within the academic side, Professor Jen Talley from NSSR was instrumental as well, and thank you, Jen. We found a way to basically support the harm reduction around alcohol and other drugs that we offered in student health services by having a team led by Jen of graduate students who provide a two-step brief alcohol screening. The new school is a little bit different from other schools where Basics operates. Basics a lot of times is mandated for athletics and for people in fraternities and sororities. We don't have either of those at the new school. So one of the challenges that we've had is how to get students to do this. And so, for example, if students get in trouble because of inappropriate drinking or use in one of the dorms, then they may get mandated to see Basics, a Basics provider. But Basics is another great example of an academic and student affairs collaboration. And one of the protocols that I learned while I was working in syringe exchange programs in New York City was the NADA protocol, National Acupuncture Detoxification Association. It's a 5-point protocol of the ear, really great for people dealing with cravings and we're just trying to manage their use. So I brought it to the university and we provide it on a weekly basis to all students. And the way we sell it isn't if you're drug using, it's, hey, come in. This is great for stress management. Come in and treat yourself, a little bit of self-care once a week. And last but not least, this idea was actually planted at the Harm Reduction International Conference in Beirut in 2011. Dr. Sharon Stancliffe and I were talking. I had just transitioned from syringe exchange program work in New York City, was now in a university setting. And we said, well, wouldn't it be great if we could provide naloxone and programs related to opioid overdose prevention at the university setting? And I said, yeah, let's do it. Came back, got buy-in from my supervisor and from the rest of the team in student health services. And then we waited. Basically, New York State Department of Health regulations did not include colleges and university as a designated prevention program. So it took about 4 years of waiting while that regulation took place. And as of July 2015, we are the first university to register with New York State Department of Health as an opioid overdose prevention program. So this last summer, we trained all the resident hall directors who manage the 5 different buildings where, which are dorms that are part of the university. And I just had my first workshop with 6 RAs, so student leaders who manage students and residents' life, about a week ago. And I'll say that Jen is part of that OOPP work, as well as my colleagues in Student Health Services. And another great ally is our fire marshal for the entire university, Paul Gottlieb, who is also a harm reductionist and who's been part of the team that has really endorsed it and has been able to kind of sell it to security and to the housing team folks. So use the new school as an example, a case study, if you will, of the kind of programs that need to happen outside of traditional settings where harm reduction has taken place. As a harm reductionist, that transition from the trenches of work of syringe exchange programs into more I would say non-harm reduction settings traditionally, but we're trying to change that, right? So we really made harm reduction the core of what we provide in wellness and health promotion. And I really think that colleges and universities across the US are ready for this. We're kind of lucky that we're in New York City and New York State because the laws have allowed and the regulations have allowed for that integration to take place. There's my info. So thank you very much.
As a father, even though I am a psychologist, I think nothing breeds more anxiety in us than the idea that our children are using drugs or drinking. The idea of adolescents, teenagers getting high makes most people, most parents at least, very anxious, no matter how much you work in the field. Many communities, as you probably know, again with this issue, is this about illness and health, or is this about punishment? Many communities in America were part of the DARE program, right? You see the DARE t-shirts, people walking around. You may probably know this, but you may not know this. It was in a series of a couple of major studies of the DARE program. It was found that students who went through DARE were actually more likely to use drugs than if they didn't, which was a complete disaster. Again, having a policeman, no offense, a policeman come to your classroom and talk about drugs may actually not be what is needed here. The Drug Policy Alliance, I think, has been a major leader in what they call school-based or reality-based drug education, of really talking to students about their experiences with drugs, about their friends who use drugs, about perceptions about how to use drugs wisely and safely, or more safely at least. And I think in all these empowerment models, we want to teach people, empower people to say yes, and to say no, and to say maybe later. So with that, welcome Jerry Otero from the Drug Policy Alliance. We'll talk about youth prevention.
Which one am I going to speak at? Man, harm reduction's come a long way. We have 2 mics. Used to be a bad word, right? It's especially a bad word when it comes to young people. It still is. In fact, I'll let you guys in on a secret. In the back table, there are booklets, the Safety First booklet, which is sort of our answer to harm reduction without calling it harm reduction. That's our little secret. Keep it in this room. Don't want that getting out, that it's actually a book in harm reduction. And we have this other booklet called Beyond Zero Tolerance. So those are for you guys to take, and they're sort of 2 publications that talk about how to have honest conversations with your kids about drugs, and also talk about issues that have been brought up around the prison to school pipeline, and how punitive expulsion, suspension, and other sorts of drug war rhetoric informs school-based systems to sort of exclude our kids when they need them and they need the structure of the school and of the benign adults in that school, supposedly, they need the most, and that's when we're pushing them out. But I don't want to get ahead of myself too much, anyway. It's really an honor to be here. I believe strongly in the work that the Families for Sensible Drug Policy is doing. You know, as working as a clinician for many years, both with young people in prevention, but also with adults in addictive disorder sort of treatment, substance use disorder treatment. I've learned a few things along the way, and what we've landed on and what I've landed on is that any kind of good drug policy, should I just come over here? Why don't I do that? Does everyone hear me now? All right. So any good drug policy really must be built upon 4 pillars that include prevention, treatment, harm reduction as its own pillar, at least I believe so, and public safety. And any kind of drug policy sort of shtick that doesn't really include all of these things in a balanced way is really not the answer. And when we start thinking about these pillars, and then we land on the prevention pillar, we really need to ask ourselves a crucial question, and that is, what is it we're trying to prevent? And there's going to be wide divergence in what that is. And the answers could range from we're trying to prevent any drug use, right, to we're trying to prevent the harms of drug use, to we're trying to prevent the harms of prohibition. And it's becoming more and more clear to me and to many folks, actually, that the laws that regulate and the way that we prohibit these substances often causes, if not equal harm, but has the potential to cause even more harm than the drugs themselves. We could argue that, but I think we'll agree on the fact that prohibition does cause some harms, right, and has potential to cause harms. The field of prevention has evolved over time with so many different models emerging. It's kind of hard to know where we've been, where we're going, where we're at. There's developmental models, there's informational models, there's models that focus on psychology, building self-esteem, building resistance skills, and so on. Unfortunately, these many programs, however, are not based on any model, but are simply based on what stakeholder preferences are. And not a great example, but a good example to illustrate it, not a great example, but one that illustrates the point is just say no, right? We know that that doesn't really work. At least as kids get older, it doesn't work. It might work for 5th graders or 6th graders when they're sort of more in the sphere of adults' influence, but it doesn't work beyond that. So really, the models that these programs that your kids are forced to sort of take, right, in school and so on and so forth, are really not based on anything sound, and that's a crime. I think because no parent wants our kids to be using drugs, and I think there's nothing that freaks a parent out more than having a kid who's having trouble with drugs, because there's no real sound information out there. Go online and look for something, and you're going to find all these polarized sort of arguments, right? Telling you to get tough and shaming you as a parent to take a tougher position than you might normally take, and to go against your better instincts as a parent. And I think and shaming you into doing so. But needless to say, as youngsters approach as they get older, right, as they become older youngsters, teenagers, the topic of drugs becomes much more relevant. Kids aren't just simply abstaining from using intoxicating substances. In fact, maybe someone can guess. What do you think the most reliable research tells us? What do you think the rate of drug use prevalence amongst high schoolers by the time they finish high school is? 10%? 20%? 30%? Keep going up? 40%? 50%? It's about 50, 60%. If you throw alcohol into the mix, now we're talking maybe 70, 75% of kids are going to use a substance by the time they get out of high school. And, the unfortunate thing is that we don't do anything to prepare them for that ultimate encounter that they're going to have with drugs or with alcohol. And I don't think that every kid is bound to use, but if you let them sort of run wild, if you let loosen control rather, that they're going to lose control themselves. But it's well known that over half of teens will use. You throw alcohol into the mix, it's 70 to 80%. So what's going on right now somehow isn't working. If what we're trying to prevent is drug use, all drug use, then certainly what's going on is a miserable failure. And as David Simon says in the film The House I Live In about the laws that regulate drugs, it's draconian. If it were draconian and it worked, then we might have an argument here. But it's sort of punitive. These measures are punitive, and they don't work. So we're subjecting our kids to these needless sort of interventions, that go back to the 19th century temperance movement, that rallied against alcohol, to, as I'd mentioned, Nancy Reagan's Just Say No campaign, to current iterations of drug prevention and education programs. We mentioned the DARE fiasco, and there certainly is a lot of research that shows that DARE students are more likely to use drugs than not. And believe it or not, they've reformed their program. They've pulled marijuana out of their list of priority substances, and they've got a new reformed DARE. And I'm sad to inform you that the new DARE is at about 30% of our schools throughout the country. How did this happen? When they're absolutely forbidden, any county or government agencies are forbidden to spend any government money on the DARE program because they've been just found to be ineffective, yet they persist like a bad penny. Anyway, so through all these programs, temperance movement, on and on and on, Just Say No, current iterations of the program, Americans have been trying to prevent teenage drug use, right? And some of the narratives that fuel that myth are the well-worn stories of how teens are unreasonable, they're crazy, right? And if you let go of the controls, they're going to lose control. And the only reasonable approach, and this goes back to sort of like a Margaret Thatcherism, right? The notion of Tina, there is no alternative, right? Which was used to promote harsh sort of economic measures, right? With the idea that there was no way around it. And I think many of our much of drug war rhetoric that has led to sort of these policies are informed from that same there is no alternative. And so we're fed this singular diet of sort of these tough love approaches, right? And that is driven by the fact that teens are unreasonable. They need to be scared straight. And that drugs have their own gravitational pull. Now, that's not necessarily untrue, because there are drugs that have their own physiological sort of dependency, sort of trajectory, and that can't be denied. But we're convinced that any drug use will snowball into problematic use of its own accord, right? And those are some of the narratives that fuel the myths and fuel the well-worn narrative about why we need to scare our kids into being straight. None of these sort of approaches take into account that adolescence is a state of flux, and that experimentation with risky behaviors, including drugs, is pretty normal. Instead, we see scare tactics, resistance techniques, zero-tolerance policies, random student drug testing, and all sorts of other punitive measures that are used to try to persuade, to coax, to force people to abstain. But guess what? Are kids hearing us? No, I think they've gotten real cynical over the messages that blast out of their radios, that are resurface over and over again, especially as we start to see more or less punitive drug laws, especially around marijuana, for instance. We see the reefer madness kind of messaging reaching new levels, and we thought that they were gone, but they're back. Parents, too, have been bombarded with anti-drug messages that urge them to talk to their teens about drugs' dangers. And, of course, those who've experienced, children who have had problematic drug use problems, the gratuitous advice that is offered. No other issue elicits as much gratuitous advice as having a child with a drug problem, right? Let him hit bottom. And parents are often shamed into taking a much tougher stance than they might normally do. But let's face it, let's get back to drug education for a second. You know, if driver's education consisted of nothing more than scary video footage of pile-up accidents on the highway, no one would ever learn to drive, right? I mean, and that doesn't mean that we want to teach young people how to get high, necessarily. But what we want to do is engage them in the process of thinking about these things critically, thinking about these things as life decisions, and that they need to enter into these decisions with some intention and deliberation. You know, if we can start accomplishing that, we're going to see less problematic use. And that's what I'm really trying to prevent, is the problematic use side of things. So most drug education and prevention strategies, and I'll wrap this up, are compromised by one or more of the following. They're compromised by the unwillingness to distinguish between use and abuse. All use becomes abuse. The fact that most drug use is illegal, and then if you make it for underage people, it's even more illegal, right? It becomes an antisocial problem as well. And a lot of treatment is predicated upon this sort of pro-socialization, right? That is rooted in the fact that using drugs is against the law. I think that's a real problem. The use of misinformation is a scare tactic, and the failure to provide comprehensive information to help young people reduce the harms that can result from their drug use. Keeping young people safe must be our priority, our highest priority. Abstinence-only, zero-tolerance approaches do not prepare young people to function in a world where they're bound to encounter drugs. A reality-based approach gives youth the tools they need to make responsible decisions about use by providing honest, science-based information. And as our colleague, Dr. Carl Hart, has said about drug education, it must rely on science and be informed by the facts, even when those facts make us uncomfortable. So we need to provide honest science-based information. We need to encourage moderation if youthful experimentation persists. We need to promote an understanding of the legal and social consequences of drug use so that people understand time and place restrictions, and that it's never really cool to be getting high if you're doing things like school or you're working or you're operating machinery. I mean, simple messages, but ones that I really convey an understanding and promoting one thinking about the consequences of one's use, and also prioritizing safety through personal responsibility and knowledge. And we want people, as I mentioned earlier, we want people to be safe, but we want them to have experiences where they've been engaged in the process of thinking about these things and whether or not they're going to use them. So I've been working with another colleague of ours, many of you may know him, Stanton Peel, whose book I recommend highly, Addiction Proof Your Child. It really talks about some of the things I've been discussing in here today about getting away from preventing drug use and moving into sort of a different realm of being able to prevent addiction or addictive problems or problematic drug use. I think that as you know, the book a few years ago, using addiction was a word. Now we don't use it. We're moving on from that, but that's okay. The book is still relevant. So here's some principles of reality, safety-based drug education and prevention, and some basic principles of harm reduction with kids. Because when you start to talk about harm reduction, it begins to make sense, especially in today's landscape, when you talk about reducing the harms for problematic drug users who may not want to stop and who have serious problems with it. So to do a needle exchange, for instance, with IV using groups, that may make sense. But when you start to talk to parents about harm reduction, all they hear is that you're being permissive. And I'm getting the 1 minute mark, right? So I'll wrap it up. So I'll go through them real quick. There's never been a drug-free society. And as the drug landscape becomes less punitive, this is probably less likely than ever. The zero-tolerance approach, which prescribes strict, potentially life-altering penalties for substance use by youth, is more harmful than the drugs themselves, most especially to youth of color, to whom the zero-tolerance approach is generally applied. Drug education must provide the best information on substance abuse available, including accurate, realistic, useful warnings about the dangers of drugs, things like don't mix, don't mix tranquilizers, painkillers, alcohol, therefore avoiding accidents, unwanted sex, and so on and so forth. Drug education for older teens should include the possible benefits, not only of things like cannabis, but of psychedelics and some of the things, so that they can begin to get an understanding of the medicines of the culture and to be able to put them into a context. And drug use should not be presented for young people as the sole cause of life's problems, as though problematic drug use occurs in a vacuum. Instead, applying harm reduction to young people means recognizing that most of the life-threatening or life-limiting problems facing youth, like pregnancy, sexual disease, criminal involvement, and other stuff, are life problems on their own that may cause or reinforce substance use problems. I'll leave it at that. No, seriously. I could go on forever, but I'll be more than happy to answer more questions as this goes on. I want to hear from the rest. Thank you so much for your time tonight.
I just wanted to sort of amplify something Jerry said, but that Ken Anderson has really championed, is the finding that many people who are dying from opiate overdose have actually mixed substances, and that it seems to be not just the use of OxyContin or Vicodin, but it's OxyContin with alcohol or other pills, and it's this mixing which is really a huge problem and a very deadly behavior, but that message is not getting out as far as I can see. But Ken, if you raise your hand, is the expert on that, and he will, I'm sure, be happy to talk to you about that. Looking at the history of harm reduction, so harm reduction itself began in Liverpool, England, and Rotterdam in the Netherlands, and it began in the late 70s, but kind of picked up steam in the early 80s with the outbreak of the HIV/AIDS epidemic and the understanding that IV drug use was a risk factor for contracting AIDS. It was in some ways, certainly was a grassroots movement to say the least, but also was a movement where HIV took precedence over abstinence from drugs. So it was a whole shifting of kind of our way of looking at substance use, gradual change, trying to keep people safe, trying to keep people alive. And it was, I think, for those in the addiction field, it was a profound shift in the last 40 years, really, in our understanding of addiction. I think as it's developed, not only has it gone to working with people who are actively using, but also the issue of social justice and oppression. Certainly in America, no group has done more than the Harm Reduction Coalition to really promote this vision, to champion harm reduction, despite an incredibly hostile environment that continues to this day. So with that, I'm happy to welcome Daniel Raymond up here. There you are, sorry, from the Harm Reduction Coalition.
Good evening, everyone. Thank you for having me here. I wanted to reflect a little bit on how we think about and talk about harm reduction as an opportunity to look at what this moment that Carol and Barry talked about might mean, what possibilities might open up in how we arrange our policies and our strategies around drugs, our responses to drugs. And I think a lot about policy because I'm the policy director of the Harm Reduction Coalition. And what that means is that while a lot of my colleagues are doing things like training and doing education, my job is to take some of the innovations at the grassroots level out in the community and try to figure out what the best practices are, what's working, what the barriers are, and how to elevate those. I do a lot of my work at the national level, so elevate those in the broader public policy dialogue around drug use. And this is a very interesting time. Feels to be a lot of openings coming from a lot of different directions. Scott mentioned a lot of the foundation for the harm reduction work and the harm reduction world in the United States was built on the HIV epidemic. We've actually had tremendous success in this country and in many other countries in reducing new HIV infections amongst people who are injecting drugs. We have had less success with hepatitis C infections, which are also transmissible through shared injection equipment. But I think a lot of the energy in what, in my harm reduction community, has shifted in recent years towards recognizing that while HIV posed a clear and imminent threat to the health of our communities, of our friends, of people who are injecting drugs. Once we started to get a handle on that, once we established our needle exchange programs, once we had good syringe access, and this is really part of my experience too, we started losing people to overdose even if we'd saved them from getting HIV. And so overdose over the last really 10, 15 years has become a significant driver in the broader harm reduction agenda of people working with heroin users. What were we doing to protect people? We were doing a really great job in engaging them, in doing outreach and connecting with them, in building support, building relationships with them. And we were doing a fantastic job in helping them acquire the tools and resources to prevent their risk of infection. So we were keeping them healthy, but then this other thing was happening, right? And this wasn't the only harm that people were experiencing. People were experiencing homelessness. People were experiencing a lot of incarceration. People had a whole range of harms that we were trying to address. But one of the innovations that came out of the harm reduction community is to step back and say, what do we know about what happens when somebody overdoses? And what do we know about what might change the outcome of that scenario? And so, as Scott mentioned, there's a lot of kind of clinical or chemical factors that go into an overdose in terms of how much you're taking, a question of dose, a question of potency, a question of mixing drugs. But there were also some social and environmental factors that seem significant. When we started asking people about their overdose experiences, it became clear that a lot of people were overdosing in the presence of another person. They were overdosing with their friends who they were maybe getting high with, or who were just social acquaintances that they were hanging out with. Those friends maybe didn't recognize until late into the overdose process that something was happening. And then they tried to respond. They wanted to try to help, but they didn't know how to. And there were two things that were going on. One was that they were afraid to call 911 because this involved drug use and somebody could get arrested. Maybe they were in a home where there were children that could have potentially gotten taken away. Maybe somebody was on parole. So there was this fear of calling 911, calling for help. But there were also these efforts, these kind of homegrown sort of urban legend efforts. I hear that if somebody's overdosing, the best thing to do is to throw them into a cold shower. Or if they're overdosing on heroin, maybe if you give them cocaine, that will counteract the effects. Now, I think this tells us a couple of things. One is that the usual systems for help, calling 911, calling emergency responses, this population, because of stigma, because of fear, because of criminalization, they felt that those options were not viable for them. And yet, they were not at all interested in abandoning their friends, their peers. They were trying to help, and if they just had the right information and the right tools, then maybe they'd be able to respond differently. So what would have happened if that ambulance showed up? Ideally, they, either on the scene or when they're transported to the emergency department, they would have been given an antidote to a heroin overdose. It's a drug that blocks the effects of heroin. It's called naloxone. Sometimes it's called a brand name Narcan. And it's very effective. It's very analogous to an EpiPen for somebody who's going through an allergic reaction. And what it turned out was that this antidote was actually very safe to use, and it was very simple to use. Now, with most medications, you want somebody who's got a lot of medical experience and professional training who's actually capable of prescribing them or administering them, because people might not know when to use this medication, so you need that medical degree, that nursing degree, that MD to understand the pharmacology. You need a pharmacist to understand who to dispense it to. Maybe some drugs have different doses for people depending on their age or their size or their body weight. Maybe some drugs you can't take if you've got an underlying medical condition. So you need to take a full medical history before you know when to prescribe it. Maybe some drugs can cause allergic reactions or other kinds of side effects. So these are all the concerns that we typically think of when we think of medications and why they need to be administered through the proper channels in the healthcare system. But it turns out that this drug, this antidote for a heroin overdose, naloxone, did not come with any of those concerns. You could administer it safely to anybody. If I had 50 vials of naloxone, I could give them to every single person in the audience. If you are currently on an opioid, a painkiller, or heroin, you might go through withdrawal. If not, nothing bad will happen, right? So it's a very safe drug to use. There's no contraindications. And that profile meant that it was feasible to actually say, well, why do we only reserve this for the emergency departments and the ambulances? Why can't we just give this out to the very people who are most likely to witness an overdose and most motivated to try to respond? And so that was the premise of the overdose prevention movement, is that we could equip people who use drugs themselves to save each other from dying of an overdose. We spent a lot of time in the early years doing pilot studies, evaluations, feasibility studies, focus groups. Can this work? What kind of training should we do? How much should we talk about recognizing the signs and the symptoms of an overdose? Because it started to become clear that some people didn't know when an overdose was happening. They just thought somebody was dozing off in a heavy nod, sleeping. Maybe they're snoring a little funny, but they're okay, right? How do you recognize when an overdose is happening? What are some of the risk factors? That thing about mixing drugs and the situations where somebody might be especially vulnerable to an overdose because they've just been released after a period of being in jail, their tolerance is lower, or they've just gone through some kind of treatment program, some kind of halfway house where they haven't been using, and they relapse or they use again and they don't realize that amount that they were using before, their body is not going to be able to tolerate it the same way. So these other factors that can drive risks of an overdose, we also wanted people to know that. And then how to use the naloxone, right? We are at a point where we now have a few different formulations of naloxone, but at first it was a simple intramuscular injection, right? You didn't need to find a vein, you didn't need to do anything except give it into the muscle in the arm and the thigh. So we did a lot of work talking to and listening to people who use drugs, who had the biggest stake in solving the overdose crisis, and saying, how can we make this work? And we had fantastic results. And so what happened is that as we were doing all this formative stuff, all this evaluation, we've been focused on the people coming to needle exchange programs, the out of treatment or in between treatment or on treatment but still using heroin users. But what happened, kind of almost not quite a parallel universe, but around us was this emerging prescription opioid epidemic, this crisis around painkillers, around OxyContin, around Vicodin, around all these painkillers that were suddenly being marketed and prescribed much more broadly. And they're very chemically similar to heroin and similar in terms of the effects if you're using them recreationally. And it didn't take long for people to figure that out. And because they came in a bottle from a pharmacist who you take in your doctor's prescription to because they were approved by the FDA, they seem safe, right? They come in a pill bottle. If a doctor's prescribing them, they can't be that dangerous. Well, it turns out that, again, the wrong doses or the poor tolerance or you're mixing drugs, they can be very dangerous, and they started driving up the overdose rate to quickly surpassing the number of overdoses we were seeing nationally for heroin, right? So our major overdose problem was suddenly from these prescription painkillers. So a lot of us in the harm reduction world said, well, we've been focused over here with the people that we see, the people that we work with, heroin users. What can we do to start taking the solution that we've found in terms of equipping people with naloxone and spreading it more widely? And it turned out that there were a lot of kind of barriers to figuring out how to make that happen. A lot of the people who were using prescription painkillers weren't necessarily coming to needle exchange programs, or they were using, even if they were crushing up these painkillers and injecting them, a lot of that was happening in rural areas where there'd never been sufficient political support or mobilization to have a needle exchange program in the first place. So we started kind of figuring out what we can do as advocates. And one of the things that emerged as the most potent set of allies for this advocacy ended up being parent and family groups. Early on in Massachusetts, we had needle exchange programs that were starting to implement naloxone. They were starting to run naloxone programs parallel to their needle exchange programs. And meanwhile, Massachusetts was an early harbinger of what we're seeing now in New York, Staten Island, Long Island, really many, many parts of the country, this resurgent heroin epidemic, on the tails of this broader prescription opioid crisis. So Massachusetts was seeing heroin a lot earlier than a lot of other parts of the country. They were seeing it rising, and parents were starting to lose their children to heroin overdose. They were starting to worry about their kids overdosing while they were doing anything that they could to help them, to support them, to try to get them help, to try to get them into treatment. And when they heard that these needle exchange programs had this antidote and were giving them out, they were outraged. Not because the program shouldn't be doing this, but because why didn't anybody tell us? We've been lying awake at night, worrying about our kids, worrying, am I going to get that knock on the door, or my kid's not home in bed yet and it's 2 a.m., are they coming home tonight? Why didn't anybody tell us there was a solution to this fear? So these parents in Massachusetts started organizing and demanding access to naloxone. And they were instrumental in Massachusetts becoming a leader in overdose prevention. And that movement has spread to a lot of other places. One of the first kind of policy challenges in broader access to naloxone is that it does remain a prescription drug, and there are concerns about liability from prescribers, liability if you're administering it. So these groups started to come together, work with other advocates, and take the lead in demanding broader access to naloxone. So we've seen this just over the last year in places like Florida, places like Indiana, places like Kentucky, places like Minnesota. We even have some state legislators who themselves are parents who have lost a child to overdose or who have walked with their child in their struggles with substance use disorders, who have been spearheading this legislation. So one of the things that is novel to me about this, I've been working in harm reduction and doing harm reduction policy and advocacy for a number of years, and a lot of the times it's felt like we're the voice in the wilderness. We're those kind of crazy, radical people who are saying, let's just give everybody syringes, or let's maybe not lock everybody up. And suddenly we have these other voices that have a lot of credibility and a lot of emotional power behind them, who are walking this walk with us. And I think one of the lessons for me is that the harm reduction movement has been too timid in going beyond our own circles, because we have a lot more common ground with people than we think. I think that I've tried to, as Tamara did, use naloxone as a kind of case study for where we're seeing tremendous and very rapid public policy and public opinion shifts. We have a Republican presidential debate where a candidate talks about losing her stepdaughter to an overdose, and where we have candidates saying, I don't think we should be locking people up, I think we should be providing treatment for them. This is a massive shift amidst a much broader shift around rethinking mass incarceration and criminal justice policies. And these are dovetailing around alternatives that are grounded in public health, grounded in evidence-based treatment, grounded in harm reduction. But we have to make sure that we don't squander this opportunity. And this is going to take a lot of different voices, not just the professionals, not just the interest groups, but really in broader sectors of communities. And those sectors are coming together. I don't know if anybody else will be there, but in a couple of weeks there's going to be a huge rally in Washington, D.C. on the Mall called Unite to Face Addiction. And it was driven by, initially by a lot of groups of people in recovery. It's also been joined by parents groups, family groups, harm reduction groups, drug policy groups, but really more and more different sectors are coming together around it. So I think that we have a lot of different opportunities to start to rally and mobilize differently, because there's this huge sense of crisis right now, but there's also this huge sense of opportunity. And I see the future of harm reduction moving much more diffuse. Instead of concentrated in certain pockets of public health and certain pockets of the HIV response, we're hearing a lot of examples today of how it's applicable much more broadly and how people are taking it up and saying, this makes sense to us. If you want another opportunity to hear about harm reduction, I've left some flyers on the back table. Next Wednesday evening, there's going to be an event hosted by Amy Goodman talking about public injecting around the world, but focused on the implications for New York City. And it's going to introduce some interesting ideas about whether it makes sense to have safer injection facilities in our country. So I'd be happy to talk more about it, but I'd encourage you to check out the flyer in the back in the event next Wednesday. Thank you.